Can you guys hear me? Yes, thank you. The troubleshooting with the AirPods or the earbuds can be quite annoying. Okay, everybody is in. I'm gonna quickly drop. Oh. I'm gonna go ahead and take attendance real quick, and then we will get started. So a lot of the stuff that you are going to be learning, this week, a lot of the stuff that you're going to be learning this week, like with the gingiva and everything like that, you're going to get in my class in process of care. Then you're going to turn around and get it in perio. You're going to, it's kind of a hard concept to grasp right now, why all this stuff is important, but it is important whenever we're talking about when we get to the disease part of everything. So I know it can be a little like, why do I have to know this? But there is a rhyme or reason for it, I promise. All right. All right, so we have Miss Sam, yes, and we have Miss Jeanette, and we have Alicia, and he's not going to be with us today, Shelby. Shelby, here, got it. Okay. Mary Beth, Gilbert, Elena, sorry. Courtney, yep. Amanda, April, and Tara. Yep. Okay. Brianna. Yes, okay. Natalia. Yes. Devin, I know from him. Brittany. And that's it. Okay. All right. I'm trying to get myself situated with this camera. There we go. Okay. All right. Any questions about chapter 9 that you have? No? Okay. All right. So we will go on to chapter 10. Now, I'm going to go through chapter 11, but I have posted this morning, I posted the recording that I have there are 2 for chapter 11, because that I had made last time I taught this class, that you guys, it's a review of that, but we'll kind of go through this. If you will notice, there are, when you're looking through the PowerPoints, some of the PowerPoints are like 100 slides. I'm not going to read 100 slides to you, because as you can figure out, like the book, basically, I'm going to highlight the important parts. Okay, so let me close out of that. And then, okay, so the measurements for the right, so thank you, Philbert, because that was somebody else emailed me about this. The measurements are going to be exactly the same. It's just, remember, because I feel like it will help you identify the difference between the way a left tooth looks and a right tooth looks. If you were looking at the measurements are going to be exactly the same, but if you're looking at that right that right lateral incisor, it almost has like a little angulation on the incisal edge. And I think it dips down on the distal portion of that tooth. What I'm looking for is that you have that same type of, on that distal, just on the, like, does that make sense? I just want it to be flipped. Because what I noticed last time is I made everybody, because it was easy and it was in the book, I made everybody do a right tooth. But then when it came to identifying later, like when we get into tooth morphology next week, and we do, I will do like, I'll have like a PowerPoint picture up there, and it'll have the 5 different surfaces of the tooth, and you have to determine whether it's mesial or, I mean, whether it's a right tooth or a left tooth. And I felt like I put the students at a disadvantage, making them just know what the right side looked like. They had to know what the left side looked like too. Notice that the root curves towards the distal of the anterior tooth. So you want to make sure that when you're doing that left side, it's curving towards the distal. Is this making any sense, or am I just talking gibberish and you're like, ah, gibberish? Okay, because here, let me, I'll show you real quick. Let me see if I can pull this up. Okay, so you can see here that this is a canine, right? And I'm going to let you know that this is tooth number 6. So it is your right canine. Do you see how that apex flares towards the distal? Because here's your mesial portion, here's your distal portion, and then here's your, and this is the facial of that tooth, right? Okay. And I don't, let me see if I have the, again, this is a central incisor. You see how it does that little flare to the distal, and I'm hoping I have, as I'm going through this, I'm hoping I have I do have mandibular. Okay, so this is the mandibular right lateral incisor. Okay, so you can see how it kind of has a slight dip, like it's almost more curved on the distal surface. This is more of an angle. This has more of a curvature, and then your root goes to the disc. It kind of tilts towards the distal. Let's see if I have another one. So this is tooth number 24. So this is a left lateral, a left central incisor. A little more, but still you get that dip, that little bit of a flare. Do you see that? So what I'm looking for is that you have acknowledged the fact that if there's a tilt in the root a little bit to the distal on the right one, there should also be to the distal on the left one. And like let me see if I have, nope, that's canine. That is number 25. Okay, nope, that's where I stopped. All right, let's go back to that lateral incisor. So this is the facial portion. This is number 26. So you'll want, when you're doing 23, you'll want that this curved end to be over on this side and this end to be over on this side. Does this help anyone, or did I further confuse you? Speak now, or else I have no idea.
I have a question. Are the mesial and distal, is everything still the same on those views? Is it just different for the facial and lingual?
So when you're looking at so here would be the distal of number 26. Yeah, and this would be the mesial of number 26. Look at, it will just, where it says the distal portion, it'll be, the distal portion will be exactly the same. Like wherever the curvature is. All of that is going to be the same, yes.
Okay, thank you.
All the numbers are going to be the same. It's just the direction of the flow of how it goes, right? Like the specific parts, like this part and the root angulation.
So if I'm to take the labiolingual diameter at CEJ, how do I do that?
Labiolingual would be from here to here at the CEJ.
Say that again, please.
Do you see my arrow, or let me see if I can? So your labiolingual will be, here's your labial, and then here's your lingual. It's going to be this diameter.
Okay.
How long it's going to be across this way.
Okay.
At the widest point.
Oh. So, but without the CEJ, is that also going to be the same measurements?
So this line right here is your CEJ. Yeah, all those numbers are going to be the same.
Oh.
Because it's the same tooth. It's just on the other side of the mouth.
Yeah, I get that. But like if they say labiolingual diameter at CEJ, there's another one that says labiolingual diameter. What I'm saying is the distance, is it the same thing or there's a difference?
So I have to go grab that other book. Hold on. All right, so in Appendix C in your actual book, it says, because the numbers are all so it actually, yeah, because it just has the one tooth. So the tooth number, the measurements are still the same. So we're looking at the mandibular lateral incisor. So the cervico-incisal length of the crown is going to be the same. It's going to be 9.5 from the cervico-incisal. So from the incisal edge to the CEJ, you're going to get it's going to be 9.5 length. So that means, let me draw. So this is the cervico, and this is the CI. Oh, I don't write well with my mouse. So that's the cervico-incisal length of the crown. Your root length is going to be the same. That's from your CEJ down to the apex, okay? Your mesial distal diameter of the crown, that's gonna be from here to here at your widest point, your mesial to distal. So you're gonna, that's here to here, right? So that's your mesial distal. And then your labiolingual is going to be from here to here. Or from the distal, it would be here to here. Sorry for the wavy line. So it doesn't matter. It's going to be the same. It's not like it's going to be a different width. Does that make sense?
Yeah. So in other words, it's just like doing the crown into three, like dividing the crowns into three, and just like measure the longest parts. I don't know. I'm just trying to, yeah.
That's going to be the number you're gonna. Like, so, and, I know what I can do here. Hold on. Where's my whiteboard? Well, I can do it here too. Let's see. See how talented I am with this. Let's see if I can do this. All right. I'm going to take you guys, move you up here, and then I'm gonna, nope, something grid. Sometimes it'll let me pick the different paper. And then I use a different one. Hold on, because I can stop screen sharing. Because I have a whiteboard on here that'll do it a little differently. That's not what I wanted to do. We can just come up here. Okay. So if we're going off of these numbers, right? 9.5. So we have one, if we start, why is my pen not working? No, it's not letting me draw anything. Hold on a minute. I'm trying here, guys, sorry. And I have, let's see, if I am trying to draw this, and it is, let's see, is this gonna let me draw? Let me draw with my finger. No, what is going on with this thing? I think my battery's dead on this. All right. I'm failing epically, so we're gonna stop the screen sharing. This isn't working. So each square is going to be 1 millimeter. So if you're doing like I said before, if we're going back to this one, and you're doing the cervico-enamel or incisal, cervico-incisal, it's the CEJ up. You're going to take that longest number. And then here is your mesial to distal. Your labio to lingual is your side view. And then your labiolingual diameter at the cervix is 5'8". So this right here is this diameter is 6.5, but the labiolingual diameter of the crown at the cervix is, this is your cervical line and how the curvature of it. So it's going to go from here to here. So you're going to get that 3. That's 3. And then the curvature on the distal is different. It's more of that, it's lower. So that curvature is 2 rather than 3. You can kind of see how this one is not as high as this side. So when you're drawing this picture on the distal of number 20, on 23, you got to remember that that curvature is not going to be as high. So it's the same surfaces that you're looking at. You're just looking like it's just different, a different tooth. But it might be hard to follow if you don't know the surfaces of the teeth. So does everybody understand that the mesial portion of the tooth is the one closest to the midline? The distal is the surface away from the midline. And then you have your facial on the front, or your buccal that faces the cheeks. And then palatal on the lingual of the top and lingual on the bottom. Lingual on the bottom is a lingual, but the top they call palatal. Does this clear anything up, or did I just make things a lot more confusing?
It's okay. We'll figure it out.
I'll try to get my pen working, and then I'll make a quick video and then I'll send it, okay? All right. Probably go in our room. No, mine.
Can I open it?
Sure. The mail lady comes and I swear my kids are like, oh, mail lady, it's all for me. It's not for you. Nothing's for you. All right. That's why it won't go away. Nope. All right, so here's the lesson for today. Okay. Stop sharing. Let me go back over here, reset it up. So confusing. Okay. If anyone, I'm trying to keep an eye out if anybody else shows up, just to, just let me know. I know I think we're missing one person. Okay. All right, so we're going to talk today about the gingival and dentinogingival junctional tissue. So this is the tissue a little bit more microscopically. We talked about the lining mucosa, what? Oh, yeah, Levi. So we talked about the lining mucosa, the masticatory mucosa, and now we're going to go a little bit more like into more of the tissue that surrounds our actual teeth and the tissue that we are going to be very concerned with. So gingival tissue properties. So gingival tissue is in the oral cavity. It is the most important tissue of the oral facial region for us as dental professionals to know and understand. It's also very challenging. All of the periodontal therapy performed and home care instruction given are for the purpose of creating a healthy environment for the gingival tissue. Even with restorative treatment, the impact on the gingival tissue must be considered. Because if you have an overhang, it's going to affect the gingival tissue. If you don't have a smooth surface on a buccal filling, on a filling on the facial surface, it's going to affect the tissue. So those are things that are, why gingival tissue is so important and the properties of it. All right, so the anatomy. We kind of mentioned this the other day in our lecture, but I'm going to go ahead and put this up there. You'll get a lot more of this as you grow in your profession and in your education, but here are the basics. These right here are your maxillary teeth, and this portion down here is your mandibular teeth, right?
Excuse me, Ms.
Wait a
Kelly,
minute.
you're not
Yes.
sharing.
We're not seeing
not
the,
sharing.
oh, the slide.
Thank you. Thought I was. Here we go. Let's try this again. Thank you. You're like, you're pointing to something, but it's not, we can't see it. Fantastic. All right, so this right here is our maxillary, these are our maxillary teeth. These are our mandibular teeth. Do you see this black dotted line? This is our mucogingival junction, okay? This separates our lining mucosa from our masticatory mucosa on our tissue. Okay, see, things get all confused. I didn't see him. Say that he was, I didn't see the pop-up. No, that said he was waiting. Excuse me for 1 minute. Okay, I'm back. All right. Let's see. They don't quite understand the concept of I'm here, but I'm not here. All right, so black line here is your mucogingival junction. That separates, as I said, your lining mucosa, as you can see, your non-keratinized tissue from your keratinized tissue of your masticatory mucosa, okay? Think about it as this has to be almost a little bit tougher with that keratinized tissue because when you're eating, you're hitting those areas, right? Think about how easy it is when you are brushing and you slip and you hit this area that you end up with an ulcer, right? Because of the fact that it's thin and it's a little bit, you know, it's not as tough and it doesn't have that keratin layer on the top. So our alveolar mucosa is our lining mucosa. That is this tissue up here. And then we have our attached gingiva because you can think of it as it's attached to where, you know, around the teeth. So any questions about this before I go to the slide? No? Okay. And there it went. All because I hit it. Can you see it? Yes, okay. All right. So the gingival tissue that tightly adheres to the bone around the roots of the teeth is called the attached gingiva. That's this tissue right here. The gingival tissue between the adjacent teeth is an extension of attached gingiva and is your interdental gingiva, which forms the interdental papilla. This is this nice knife edge. That's your dental papilla. That's the area that's the area that we want our patients to clean with floss, is to get in between that interdental papilla and the tooth, okay? These are also areas that we have to be very careful of when we are, they fill in when we're probing and scaling and having sharp instruments in there, because we don't want to give them a gingivoectomy if we don't need to, right? So the interdental papilla fills the space between the two teeth. There's that contact, and then usually there's an embrasure. It's a little triangle. And so what the interdental papilla does is it fills that in. Destruction of tissue, potential, breakdown of tissue via periodontal or gum disease. And if you have a diastema, which is a space in between your teeth, that can cause a blunting of the tissue. Therefore, it's going to be a little bit blunted, not so knife edge, but knife edge with the teeth all touching is your normal, what normal looking. All right, so here's the anatomy, and we kind of touched on this the other day, and I feel like I'm teaching on this twice because I am going into much more detail for my process of care class, but I'm teaching the same material this week. So it's interesting for me, not that, okay, so you have your gingival sulcus here, and this is, that keratinized epithelium. And here, your sulcus is here. Here's your gingival sulcus. And then this is your tooth surface. Right here, you start to get, here's your enamel. And then you have your internal basal lamina. And then you have this purple line right here is your cementum. And then you get that junctional epithelium where it is, that's what this area is called. It's attached to the enamel and to the cementum, because remember, the cementum and the enamel can be in two different, it could leave a gap in between. It could overlap, it could have a gap, and it could just touch. So here is your marginal gingiva. So this is right around that, your gingival sulcus, your gingival margin is what this is called. So here's your marginal gingiva. You can see that the basal lamina is very squiggly here. You have your epithelial cells, and this is got your orthokeratinized, your parakeratinized tissue there. And then you have your free gingival groove, which is right here. And this is where your gingival, or your gingival margin, and you can see it almost lines up like a millimeter difference between there and the junctional epithelium, right? So that's where it kind of hits tight. And then you have your attached gingiva here. Here's your alveolar process, which is your bone that your teeth sit in. And then your alveolar mucosa is up here, where it is much thinner. You can see the thickness of your gingival sulcus, your marginal gingiva, or your gingival margin, your free gingiva, and the attached gingiva there. So, any questions? All right. So apical to the contact areas. So where your teeth are touching, okay, the interdental gingiva assumes an invisible concave shape between the facial and the lingual. So if you're looking at the distal or the mesial portion of the tooth, so you're looking at it labial to lingual, there is an area that has a little bit of a concavity. And that concavity is what we call the gingival caul. When you are periodontal probing, you are going in between that interdental papilla and the tooth into the area that is called the caul. It is below the contact spot and in between the interdental papilla and the tooth surface. Questions about the caul? All right, the attached gingiva is considered a masticatory mucosa, which we discussed on Wednesday. Healthy attached gingiva is pink in color with some areas of melanin, which we also discussed on Wednesday. The tissue, when dried, is dull, firm, immobile. Like when you blow air on it, it shouldn't be flapping in the wind. It should be nice and tight. Now, if a patient has periodontal disease, it may flap in the wind. The tooth might flap too, but the tissue can sometimes flap. Okay. And it varies in the amount of stippling. And if you, I'm gonna kind of blow this up a little bit to make you get a good idea. Do you see the little orange, see how this is smooth and shiny? you see the little orange peel effect of the tissue here, the little dots. That is your stippling. That is what stippling is. So when you're doing a gingival description, and this will be down the road, that you're looking for that stippling, that is healthy. Okay. So here again, here's your marginal gingiva, looking at it from a different angle, right? Here's your marginal gingiva. Here is your free gingival crest. Okay. This is your interdental papilla here. Okay. Your sulcus is like underneath that tissue. You really can't see it. This is your interdental gingiva, interdental being in between the teeth, right? Again, alveolar mucosa, shiny, vascular, smooth. This is your mucogingival junction, which I think this really gives a good, you can really see it here, and then your attached gingiva. And I know I'm kind of going over this over and over, but okay. All right. At the gingival margin of each tooth is the marginal gingiva or the free gingiva, two names, which is continuous with the attached gingiva. So it's the marginal gingiva or the, let me go back. Marginal gingiva, gingival margin, free gingiva, that's what they call this area right here. This area right here that you can, like, that is kind of free. It's not attached to anything. Does that make sense? Okay. It varies in width, the marginal gingiva, but healthy is anywhere from 0.5 to 2 millimeters. So when you are periodontal probing and you're on that facial, or the labial, the buccal, and you get a 1 or 2 millimeters, you're considered healthy because that's how deep the sulcus is. The free gingiva should be that from the marginal, the marginal gingiva, that curve in the gingiva to the base of that pocket or to the base of that sulcus should be anywhere from 0.5 to 2 millimeters. The marginal gingiva follows a scalloped pattern established by the contour of the CEJ. So remember, your CEJ is where your cementum and your enamel come together, and it is curved as well. So our gingiva follows that same scalloped curved pattern. Okay. All right. When it is dried, the marginal tissue is similar in clinical appearance to the attached gingiva. It's pink. It's dull, firm, because the marginal gingiva is considered a masticatory mucosa as well. However, the marginal gingiva, not the attached gingiva, but this margin right there, that marginal gingiva, lacks the presence of stippling, and the tissue is mobile or free from the underlying tooth, which I explained. That's why it's sometimes called the free gingiva, right? Which can be demonstrated when you periodontal probe or you blow air. When you blow air, you might see it lift a little bit. When you put a probe in there, you might, you'll, you're not going to go in there and put the probe in there, jab it in there, but it's that little bit of space that you get under with floss. I mean, think about that. That's the, when you're flossing at home. Okay, so the free gingival groove, that's this area right here, and you can see it. I mean, this is really blown up. It's very microscopic. It's only 2 millimeters. Remember, it's about a half to 2 millimeters because it's the same width depth as the sulcus. The free gingiva separates the attached gingiva and the marginal gingiva. So here is your marginal gingiva, your free gingiva, your gingival margin, whatever it is. Here's your free gingiva, and then here is your attached gingiva, right? The slight depression on the outer surface of the gingiva does correspond not to the depth of the gingival sulcus, but instead to the apical border of the junctional epithelium. So here's that 8, like I was saying, it corresponds not with the sulcus, but almost with exactly where the junctional epithelium starts to, like where the junctional epithelium is, where that epithelium is attached to the tooth. Questions? All right. So the histology, I know we discussed that the other day. It's a masticatory mucosa, the attached gingiva, and the marginal gingiva share similar histology as being masticatory. Each has histologic features that are specific to that type of tissue. And I mean, you can see, remember the paraceratinized or the orthokeratinized margin, so outer layer. All right, so the attached gingiva has an overlying thick layer of mainly paraceratinized, so this is your attached gingiva, paraceratinized, stratified squamous epithelium, which obscures its extensive vascular supply in the underlying lamina propria, which is that thicker portion, and then making the tissue appear pinkish, instead of vascularized reddish blue. So that's why that free gingiva, that attached gingiva looks more pink, because that lamina propria is a little bit thicker. The paraceratinized tissue is a little thicker. So that vascular area it's deeper than what it is in the alveolar area, the alveolar mucosa. The lamina propria also has tall, narrow connective tissue papilla, alternating with the reedy ridges, giving the tissue the varying amounts of stippling. So the marginal gingiva, from the free gingiva to the free gingival groove to the gingival margin there, doesn't have a lot of stippling in it because of the fact that it is not as, what's the word I'm looking for? It's not, there's not a lot of reedy ridges, okay? And we can go, I don't know what is going on with my computer. Okay. If I go back, you can see like in this area, there's not, the reedy ridges, you can't see the reedy ridges, but they're not in this area as much as they are in this area, causing the stippling to be there. And the way I like to describe it is the way the reedy ridges work is it holds it tight because that tissue is attached, right? So it's holding it really tight. And if you think about these like ridges that are pulling things tight, it's leaving that little dimpling, which is the stippling. Make sense? All right. Okay, so the interface between the epithelium and the lamina propria is highly interdigiated for the attached gingiva. The lamina propria is directly attached to the underlying bony jaw, making the attached gingiva firm and immobile. And then the lamina propria thus serves as the mucoperiosteum along with the periosteum of the alveolar bone. So here, the interface between the epithelium and the lamina propria is highly interdigiated for the attached gingiva. And then the lamina propria is directly attached to the underlying bone. That is important because that is making that tissue a lot more firm and shouldn't be movable. It's when the disease of periodontal disease starts to, it gets into the sulcus and it starts to break down all that connective tissue in the sulcus and goes down through the cementum that tissue starts to lose its firmness. And that's, that's part of the disease process. So in contrast, the marginal gingiva has an overlying surface layer of orthokeratinized stratified squamous epithelium. So the attached gingiva has the parakeratinized, and the orthokeratinized is on the marginal gingiva, that very outer layer. If you remember what we talked about on Wednesday, how like each layer is just a little bit different, the way that the cell is on the outside border. The associated underlying lamina propria also has tall, narrow papilla with the lamina propria, but this lamina propria is continuous with the lamina propria of the gingival tissue that faces the tooth. So the gingival tissue being that's on the tooth. So it's continuous. That's why in this picture you can, there's no breakage. The lamina propria it goes all the way. There's no breakage in it, even though you have your epithelial cells, and then you have your lamina propria, and then here's your basal cells. Okay. Any questions so far? I mean, I know that this is so flipping exciting. You can't even keep it together. I get it. It's not like, this is, it's not fun, but we have to know it. And unlike the attached gingiva, the marginal gingiva is not attached to the underlying bone because why is it not attached? What else can we call it? Anybody?
Free.
Yes, thank you, Alicia. It's free, because it's free. It's not attached. It's free. Your attached gingiva is attached. It's got a lifelong mate of having a bone, the underlying bone. That free gingiva is free. It's a party animal. Making this tissue firm but mobile. So that's why it's able to, it's able to be blown with the air if it needs to be. All right. Further, the epithelial covering of the caul. Remember that caul is that space in between the interdental papilla and the interproximal or the proximal area of the tooth. Consists of marginal gingiva because it's movable. You can put your probe in that area or an explorer in that area, except that it has a small area of non-keratinized, which I think we talked about the other day. That's why it can disease, right? In between the teeth. That's why the best way for me to describe that is the fact that, like, if you don't floss for a week, right? Probably like 2 or 3 days, but let's give it a week, right? You don't floss for a week. Where does it like hurt when you floss? It hurts where that that in between that tissue, like when you're flossing in between, because of the fact that that tissue there is, some of it is non-keratinized, so it's easier for the breakdown from the plaque. So plaque is an acid. It's going to burn. It's going to ulcerate that tissue. It's going to much easier ulcerate that non-keratinized tissue than the keratinized tissue. Everybody got? Does that make sense? Questions? Okay. All right. The lack of keratinization in the caul may be important in the formation of periodontal, blah, blah, blah. I just said that. It is important to note that the gingival fiber group is located in the lamina propria of the marginal gingiva. So the periodontal fibers, did we talk about those? The oblique, the apical, okay. This is what I'm talking about. Like I'm literally teaching the same stuff to 2 different classes. So I have no idea what I said to one class. All right, we'll talk about the fiber groups. Fiber groups are what really keep the teeth, give us that little bit of, some of them keep our teeth from tipping forward and back. Some of them keep from like you having, they're almost like shock absorbers. That's the best way for me to describe them. But we'll definitely get to that point. Where is this picture? Hold on. This one. These purple fibers, these are all fibers that there's a reason for their connection, and we will talk about them soon. Okay. All right. So clinical considerations for gingival tissue aesthetics. Obviously, the picture of this mouth is really, it's really pretty, right? I mean, for lack of a better word, it's pretty. Everything is pink. Everything. This is your picture perfect. This is your ideal, right? I mean, not really ideal. I shouldn't say that, because if you have pigmentation, the pigmentation is ideal as well. But it's the health status. Let's look at the health status. It is completely healthy. You can clearly see everything that you need to see. In a healthy situation, the gingival contour forms a silhouette around the cervical section of the tooth, a fact that should be acknowledged when considering overall aesthetics of a smile design. The cervical peak of the individual gingival contour is referred to as the gingival apex of the contour. So this is the gingival apex of the contour. Okay, so it's that nice, that curvature of it. Smile design is a big thing. These are the things that, you know, people will go in and have their gingiva cut back to make everything look, you know, those smile shows that, you know, smile makeovers and all that. That's it is related to the position in regard to the lip line with continued consideration when you're looking at the smile design. An optimum smile line clinical appearance should reveal the least amount of maxillary facial gingiva tissue when you're smiling. So some people have you know, you can see a lot of their gingival tissue, and some people you cannot. So it's the, this is that, you know, optimum contouring. Here's a perfect picture of that gummy smile. In cases of a gummy smile with excessive display of maxillary facial gingival tissue, they're not ideal. And so people will want to come in and do what is called crown lengthening. You could always do orthodontics. I mean, these are the angles on these teeth are a little, so if she was to straighten everything up, it could totally make things differently. But all right, so this here is our, you know, our gingival margin, our free gingiva here. With active periodontal disease, both the marginal gingiva and the attached gingiva can become enlarged, especially in the interdental papilla. So that would be this area, right? This spongy enlargement results from edema occurring in the lamina propria of the tissue caused by an inflammatory response. So that acid gets under the gums and it inflames that area. Like I said, it causes small ulcerations. And so those small ulcerations cause our body to want to protect itself. So, all right. McCall's festooning, and we kind of talked about this a little bit the other day, but McCall's festooning is the lifesaver shape. So like this, you can see that it looks like a red lifesaver, does it not? That red tissue right here. That is, you know, that very rolled marginal gingiva because it's inflamed in there. This is called gingival hyperplasia. This is an overgrowth of tissue or an enlargement because of, it could be because of medications taken. It could also be because of lack of brushing, but this affects both the epithelium and the lamina propria, causing a permanent fibrous enlargement. So the number one cause of this issue right here is what is called phenatonin gingival hyperplasia. This is just extra from Mrs. Calhoun's brain. And it is anti-seizure medications that can cause this. Okay. Another thing that can cause this is medicines taken to decrease your risk of infection after a organ transplant. So those type of things, but this is usually a epileptic. And then here's your gingival recession. This is where you start to lose that clinical attachment, that attached gingiva. You start to lose that attachment, and it starts to go, that tissue starts to go apically. Being that this is a mandibular tooth, it is going, you know, down. If it was a maxillary tooth, it would go up, not down. It can be a result of periodontal disease, occlusion forces, abrasion from a toothbrush method, which I disagree with unless you're using a Brillo pad to brush your teeth. But I guess there's still people out there that use a hard toothbrush. It's not recommended. Sometimes when, I mean, because here's your mucogingival junction, right? If this gets to this point, you know, we're losing all of our attached gingiva. And so here's your frenum, and you can sometimes end up with frenal like the frenal attachment can cause if you have a really high frenum, it can cause that tissue to pull back. So that is another possibility for how it happens. And then, like I said, parafunctional habits such as clenching and grinding, the age process, and then I talked about the frontal attachment. All right, and then here's your Stillman's cleft. You can see this, here's your recession on this guy right here. And on this guy, you have this cleft. So you start to get a clefting in the tissue here. And that's just a type of, you know, it's usually related to some type of occlusal trauma. Any questions about the gingival area? Here is gingival grafting. You can see the tissue looks a little different here. This is a gingival graft. So when I was in hygiene school, my mom had a gingival graft done, and her oral surgeon told her not to let me look at it because I was going to freak out. That would never have happened. I would have enjoyed looking at it, but she didn't let me. All right, so there are subepithelial connective tissue gingival grafts, and this is basically to cover these areas of recession that might be causing sensitivity or things like that. It's just to reduce the amount of gingival recession. It consists of only lamina propria that is taken from the surrounding keratinized attached gingiva, then grafted directly to the root. These pictures are in your book, but be ready because, you know, this is what they do. They go and they remove to have a good attachment, and then they come back and they put that on. Here's after healing. So this is how they stitch it on. Here's after healing, and this is I'm not, you know, I don't know what the original probe reading was, but you can see here. I mean, that's a lot because here's your attached gingiva down here, right? So you've lost all your attached gingiva. So you know, to kind of protect the tooth and keep it from, you know, you put that on there to you do the grafting to keep it from getting losing the tooth. Basically, there's nothing holding that tooth in. All right, now we're going to go to the dentinogingival junction, dentinogingival junctional tissue. So this is where the dentin and it's the junction between the tooth and the gingival tissue. So that would be this area here, the tooth and the gingival tissue. Together, the sulcular epithelium, which is this right here, and the junctional epithelium, which is this right here, form the dento-gingival junctional tissue. So it's the dentinogingival junctional tissue is formed by the sulcular epithelium and the junctional epithelium. All right. Like I said, here is your junctional. Junctional is where the tooth and the tissue come together, and then your sulcular is the inside of the sulcus, that tissue on the inside of the sulcus. All right, so your sulcular epithelium, or it's also called your crevicular epithelium, stands away from the tooth. So it's away, it's free as well, creating a gingival sulcus or a space that is filled with gingival crevicular fluid. The depth of the healthy gingiva varies from 0.5 to 3.0 with an average of 1.8. Let me just go ahead and say this now. Nowhere when you are going to be periodontal probing are you going to say that's a 1.8 because your probe only has 1 millimeter markings and we're not going to make you guess on the 0.8. Okay, everybody got that? If it's a 0.8, you're probably going to name it a 2, but I'm just saying. All right, so your gingival crevicular fluid is the adjacent blood supply in the lamina propria, and it's the usual flow of the gingival crevicular fluid is slow, calculated to 1 to 2 microliters per tooth per hour. You will not need to know that. Thus, the amount of the crevicular fluid is minimal at one time in the healthy state. Now, the GCF from the lamina propria seeps between the epithelial cells and then into the gingival sulcus. This fluid allows the components of the blood to reach the tooth surface through the junctional epithelium from the blood vessels of the adjacent lamina propria. If there is a disease going on in there, though, it does start to kick up, and you start to get other it does contain immunologic components, and although in lower amounts and in different proportions, it also contains plasma, and it has white blood cells, including the polymorphonuclear leukocytes, the PMNs, and it plays a role in our defensive mechanism against disease, which is what happens when we have bacteria in there. Let's see. All right. So the properties of the dentinogingival junctional tissue. A deeper extension of the sulcular epithelium is the junctional epithelium. So here is your sulcular epithelium, all right here, right? And then here's your junctional epithelium. The junctional epithelium is attached to the tooth surface by way of an epithelial attachment. Okay. Any questions about this? All right, so the histology. Microscopically, the sulcular epithelium contains stratified squamous epithelium, similar to the deeper epithelium of the attached gingiva and adjacent to the marginal gingiva, making it a transitional tissue between the gingival epithelium and the junctional epithelium. However, the thinner, you can see there's that thick keratin layer here, but inside the sulcular epithelium, there isn't. It is thinner, non-keratinized, unlike the keratinized marginal gingiva and the attached gingiva. Let's take a break. I think this is my kid's nurse calling. I will be right back. 10 minutes. Oh. I think next week will be a lot more fun. Oh, I'm muted, aren't I? Nope, I'm not. Okay, sorry. Next week we'll learn about tooth morphology, so it'll be a little bit more, I feel like it's a little bit more fun about the teeth, but this is the stuff that you need to know for your board, but you know. And it does help to know why certain areas of the mouth end up diseased quicker than others. So that's important. All right, so what I was saying before I speeded off was, or sped off, speeded, that the sulcular epithelium is non-keratinized. Again, we learned about the interdental papilla, and it's non-keratinized and it diseases very easily. The non-keratinized sulcular epithelium ends up that way too. So that area, whenever you get plaque into the area, it ulcerates because there's no thickening there. Like the keratinized, it's thinner, it ulcerates, and then the gingival curricular fluid becomes more because it's sending white blood cells to kind of fight things, which is why we end up with that diseased issue so quickly. Yep. Okay. All right. In addition, the interface between the sulcular epithelium and the lamina propria that it shares with the outer gingiva, because you can see the lamina propria doesn't stop. It doesn't like stop, and there's like a margin where, oh, this is for the sulcus and this is for the. It's all continuous, right? This lamina propria is all continuous, and here's your sulcular epithelium. It shares with the outer gingival tissue, is relatively smooth compared to the strongly interdigiated interface of the outer gingival tissue. So you see how this is like super smooth here. This is a lot more interdigiated. Just means that it connects that way. The deeper interface between the junctional epithelium and the underlying lamina propria is also relatively smooth without reedy ridges or connective tissue. So you're not going to have that stippling. There's not going to be that connective tissue there. It's just going to be that, like you can see that right here. It just connects right there. That's that junctional epithelium. All right. Microscopically, when you're just looking at the junctional epithelium, which again, Ms. Jeanette, do you want to tell me where the junctional epithelium, what it touches, why we call it that?
The junctional epithelium is right where the tooth meets the gingiva.
Perfect. Thank you so much. All right. Sorry to call you out, but sometimes if I don't call y'all out, y'all ain't gonna say nothing. All right. The junctional epithelial cells are loosely packed with fewer intercellular junctions using desmosomes, and we're going back to cell biology, between cells as compared with other types of gingival tissue. The number of intercellular spaces between the epithelial cell of the junctional epithelium is also at a higher level than that of other types of gingival tissue, and are all filled with tissue fluid. Thus, the overall junctional epithelium is more permeable than other gingival tissues due to its fewer desmosomal junctions and increased intercellular spaces. So it is more permeable because of the spaces. All right, you can see here's your lamina propria here. I really like to use a laser just because I want a laser. I need to go buy one. The lamina propria is here, okay? You have your external basal cell lamina. Here's your cementum, your cemento-enamel junction, where your cementum and your enamel meet. And then you have your junctional epithelium. But you can see they have these are the little hemidesmosomes, and then these have the little spaces in between. So And I like this picture because it has all the different cells are in a different stage. But here's your basal cell layer, and then here's your epithelial layer. So, all right. All right, so this increased permeability allows for the immigration of large numbers of mobile white blood cells from the blood vessels in the deeper lamina propria into the CEJ, even in healthy tissue. So that healthy tissue has a larger number of white blood cells. This mainly involves the polymorphic nuclear leukocytes, the PMNs, with those cells actively undergoing phagocytosis. In the absence of clinical signs of inflammation, approximately 30,000 PMNs migrate per minute through the CEJ into the oral cavity. So it's like constantly trying to, take care of us. But the increased presence of the white blood cells may keep the tissue healthy by protecting it from microorganisms within the dental biofilm, and also associated toxins that continually form on the exposed tooth surface in the vicinity. In addition, the junctional epithelium is also thin. It's thinner than the sulcular epithelium, ranging coronally from only 15 to 30 cells thick at the floor of the gingival sulcus, then tapering to the final thickness of 3 to 4 cells at the apical part. So it's thicker, and then it obviously goes thins out. So. All right. The suprabasal cells, which make up the most superficial layer of the junctional epithelium, serve as part of the, oh my gosh, what does EA stand for? I'm going to lose my mind. Why do they do this? Why do they throw me completely off?
I think it's epithelial attachment.
Attachment, thank you. I'm glad somebody's on it because, I didn't have my book open. Serves as part of the epithelial attachment of the gingiva to the tooth surface. So it's where the attachment of the epithelium. The more suprabasal epithelial cells of the junctional epithelium provide the hemidesmosomes and an internal basal lamina that creates the epithelial attachment, because this is the cell-to-cell nuclear type of intercellular junction. I'm going to go back to that picture, and you can see here you have your internal basal lamina, which are this white part and this yellow part. Okay. Okay. Because the structure of the epithelial attachment is similar to that of the junction between the epithelium and the subadjacent connective tissue, this internal basal lamina also consists of lamina lucidea and then lamina densa, and that you can see here too. So the densa is the yellow and the lucidea is the white. Because internal being that it's closest to the tooth, closest to the epithelial attachment, external basal lamina is the outside, closer to the lamina propria. Do you see that? Oh, okay. Now we're going to talk about the external. All right, so the internal basal lamina of the epithelial attachment is also continuous with the external. So like I said, the external is on the closest to the lamina propria, and then the internal goes up and touches the tooth, right? Between the junctional epithelium and the lamina propria at the apical extent of the junctional epithelium. The EA is very strong in a healthy state, acting as a type of protective seal between the soft gingival tissue and the hard tooth surface. What you don't ever want to do is break that seal. So when you're probing, that's why probing is such a light, it's a very light movement. It's not a hard movement. It should never hurt to be probed. So if periodontal probed. All right, so as I said before, here is our external basal lamina, and then it's continuous to where it comes in to be your internal basal lamina. Any questions? All right. Now, the hemidesmosomes are intercellular junctions which involve the attachment of cells to an adjacent non-cellular surface, which is the tooth. Note that the smaller attachment plaques of the hemidesmosomal junction and the tonofilaments of the cellular side. So here is your cell membrane, here's your non-cellular region, and then here is your cytoplasm. So you have your attached plaque, and these are your tonofilaments, and then these are your transmittable proteins. So here's your collagen fiber here, your non-cellular connective tissue, your anchoring, and then here's your cell membrane. Here's your basal lamina, this whole part, your tonofilaments, and then your attached plaque. You can kind of see how that attachment happens. All right, the deepest layer of the junctional epithelium, or the basal layer, undergoes constant and rapid cell division, or mitosis. This process allows a constant coronal migration of the cells as they die and are shed into the gingival sulcus. However, the few layers present in the junctional epithelium, from its basal layer to the suprabasal layer, do not show any change in cellular structure related to the maturation, unlike other types of gingival tissue. Thus, the junctional epithelium does not mature like keratinized tissue. Such as the marginal gingiva or the attached gingiva, it fills its matured superficial cells with keratin. So I was looking for a different picture and that's not in here. So it's instead of dying and shedding, they have keratinized in there to keep that attached. All right, junctional epithelial cells have organelles in their cytoplasm, such as rough endoplasmic reticulum, Golgi complex, and the mitochondria, which indicate a high metabolic activity. And even with that heightened state, the junctional epithelial cells remain immature or differentiated until they die and are shed or lost in the gingival sulcus. Okay, so here is your dentin. This is a microscopic image. So here is your dentin here. This white part up here is your enamel. This is all your connective tissue. Here's your cementum, which is that thin layer on the outside of the root. Your cemento-enamel junction is right here, and this is all of your junctional epithelium here, where this arrow is pointing. All right. Again, junctional epithelium, your enamel surface, and then your external basal lamina. Connective tissue is over here. So you can see that internal basal lamina is here, and that is what that's what attaches to that enamel surface. All right. Tooth development. Okay, so this is that how it all happens when the tooth is developing. Before the eruption of the tooth, and after enamel maturation. So remember, we've already started this is that blue part, that enamel part that is maturing. The ameloblasts secrete a basal lamina onto the tooth surface that serves as part of the primary epithelial attachment. So this is your reduced enamel epithelium, your REE, okay? And then here's your connective tissue and your oral epithelium. So when it starts to erupt, when you start to actively erupt, the coronal part of the fused it kind of fuses to the reduced epithelium, to the oral epithelium fuses to the reduced enamel epithelium, okay? And then it starts to, like, the tissue starts to disintegrate, and then that reduced enamel epithelium starts to peel back. Okay, the ameloblasts also develop the hemidesmosomes for the primary epithelial attachment and become firmly attached to the enamel surface. However, the cervical part of the fused tissue remains attached to the neck of the tooth by a primary epithelial attachment. The fused tissue, which remains near the CEJ after the tooth erupts, serves as the initial junctional epithelium of the tooth, creating this first tissue attached to the tooth surface. This tissue is later replaced by a definitive junctional epithelium as the root forms. So this initial junctional epithelium just kind of keeps coming, like, it stays with the enamel, but it keeps getting pulled back. And then once you remember, the root starts to, tooth starts to erupt when half of the root is developed. So as it's still developing, that's why, and it develops over time. And so I don't know if you've ever experienced like an implant for a teenager. Say a teenager is missing a lateral incisor or gets in an accident and loses a front tooth. It's highly recommended that we don't do an implant yet because of the fact that the tissue hasn't started to, not completely like in full maturation to where it's ready to accept that. So that's all later, but still interesting. Both the sulcular epithelium and the epithelium of the marginal gingiva, the turnover process, ensuring the regeneration of the tissue occurs in a manner similar to that of the epithelium of the attached gingiva. The basal cells migrate superficially after mitosis, undergo maturation, and take place of the superficial cells, which are shed in the oral cavity as they die. It's a lot of cells that die, I guess. All right. The junctional epithelium, even though it does not undergo cellular maturation, its basal cells still migrate superficially upon dividing and continuously replace the dying suprabasal cells that are disseminated into the gingival sulcus at a fast pace. The junctional epithelium has the fastest turnover time in the entire oral cavity, which is 4 to 6 days. And here's a wonderful picture of the oral cavity turnover rate. Hard palate, 24 days. For the mouth is 20. Buccal and labial mucosa is 14. Attached is 10. Taste buds are 10. Junctional epithelium is 4 to 6. That's attached to the tooth. Okay. One of the clinical considerations for dentinogingival junctional epithelium is gingivitis. It's an increased permeability of the junctional epithelium that allows immigration of the PMN type of white blood cells and also microorganisms from dental biofilm and associated toxins from the exposed tooth surface to enter the tissue through from the deeper lamina propria. When the damaging agent can enter the junctional epithelium, the gingival tissue undergoes initial signs of active periodontal disease, which is called gingivitis. Periodontal disease is the broad picture, the broad name. There are two, there's periodontitis and there's gingivitis. So both are the same, or both are considered periodontal disease. All right. Gingivitis causes redness, swelling. It's a chronic inflammation. Well, it can be chronic or acute. It has an increased number of white blood cells and epithelial ulcerations with the tissue becoming thinner. The ulcerations of the junctional epithelium allow even more damaging agents to enter the deepest part of the periodontium. So think about it, if you have an ulceration there, other things can get in there to start to destroy, other bacteria can get in there to destroy even faster. Probing, like I said, in a healthy case scenario, and taking a more microscopic perspective of what occurs with probing, the instrument is gently inserted into the gingival sulcus. It slides by the sulcular epithelium and it is stopped at the junctional epithelium. Do not go past that junctional epithelium. There's all kinds of different periodontal charting. We're not going to really get into that. Okay, periodontal pocket. Bleeding on probing with a gentle touch. So when you go in and you go to put your probe in there and there's bleeding, you know, that's, you can see that the collagen fibers are all there, the capillaries are there. I mean, everything is there, but then you have that thick epithelium. But when it starts to thin out because all of this part starts to get inflamed, it causes, because of the ulcerations, it causes an increase in blood vessels, and you know, you end up with bleeding on probing with your periodontal pocket. That's a really deep one right there. If that's a 12 millimeter probe, that's a 10 millimeter pocket right there. So that's if that's a 12 millimeter probe. If it's a 15 millimeter probe, it's 13. It's a deep pocket. All right, increased levels of gingival crevicular fluid. Periodontal inflammation is also accompanied by an increase of the GCF. It's there in order to fight the microbial attack, either with a serous, a clear fluid, or a suppurative nature, which is like a pus looking, because you've got the white blood cells, real yummy. Thus, relatively large amounts of fluid now pass through the more permeable epithelium cells. This is noted clinically only when it involves the visible whiter suppuration or pus resulting from the presence of the cellular debris and the PMNs. So here's a great looking picture of periodontal disease. You can see the recession. You can see the pulling away of that attached gingiva. You can also see the wonderful stuff that you're going to be able to scale off one day. The periodontitis is it's when it goes deeper than just the gingival, the free gingiva or the gingival margin area. It's not only that damage is already, you know, so think of it as gingivitis. You have that ulceration in the gingival sulcus because that non-keratinized epithelium. You get those ulcerations. You get all kinds of, you know, biofilm and plaques and nasty stuff that want to go in. They want to infiltrate as much as they can, right? And you don't clean it up, right? You don't brush your teeth. You don't floss. You don't try to reverse that, because gingivitis is reversible because of the fact that, like, all you have, you know, maintenance. It's when it gets to that, it progresses and gets to a point where you start to get destruction of the tissue and the bone, that you end up having the periodontitis. And it destroys everything in an apical pattern. You can have generalized horizontal bone loss, but when you start to get like this type of stuff right here, it's just pulling apically, and there's just the bacteria is just further damaging. And I, 3 weeks ago, had to hold this tooth in a mouth while I was perioprobing, because he could touch it and it would just move. Kind of neat. All right. Pathologic migration may also be present due to a weakened periodontium. Occlusal forces may not be at an abnormal level if the periodontal support is already reduced by periodontal disease. So if you start to lose the bone that your teeth sit in, the support that you get from your occlusal forces, chewing, biting, you're not going to get that support, right? So eventually things are going to, like, break and fracture and things like that. All right, so I'm trying to figure out what picture is what. Let me see what the okay. So A is the ulcerated junctional epithelium. Okay, and then B is a slightly more apical view showing the epithelial, the perforation. So you have your little ulcerations in there, and you can kind of see them here. And then you have your ulcerations, but it's starting, because you can see it pulling that way, right? Here are your reedy ridges, and then your epithelial attachment, and then here is your collagen fibers. So this is a higher magnification of the newly formed pocket epithelium close view. So even though like the tissue starts to ulcerate and pull away, and then the junctional epithelium starts to pull away from the tooth, eventually it gets to a point where it kind of makes its own attachment further down, which gives you the deepening of the periodontal pocket. And a periodontal pocket is a diseased pocket. That's why I keep correcting myself and saying pocket, and then I say sulcus. Sulcus is a healthy pocket, is a healthy area. A pocket is a diseased sulcus. So, all right. Okay, so you can see in this picture, you have a healthy, here's your junctional epithelium here. You put your probe in, I don't know what type of probe this is, but maybe that's a 3. So you get a 3 millimeter reading. For a disease, you start to get the migration of the junctional epithelium. So it's not up here anymore, right? It's way down here. And you start to get resorption of the bone, because here's the bone in a healthy state, and here's the bone after destruction of the tissue. Here is, tartar or calculus. That tartar and calculus are the same thing. Calculus is what the professionals use. Tartar is what we tell our patients. Layman's term, but you can see here, you have it, but there's still a nice attachment. So you're able to get that, no problem. But then it gets deeper, and then it starts to pull away. And so your junctional epithelium starts to go more apically. Any questions? All right. Periodontal pathogens within the periodontal pocket are believed to play an important role in periodontitis, such as this is where actinomyces, this is when I ask Siri how to say it, because I can never say that many syllables in one. So, but the Porphyromonas vallis, I know it's the other one. It's the Agrobacter, actinomyces mutans. I get so confused on. So, all right. So it's AA and PG. P. gingivalis, that high. Porphyromonas gingivalis is found everywhere in your body. It's found in your brain. It's found in your heart. It's found in your joints if you have rheumatoid arthritis. It's found in your bloodstream. It can affect your diabetes numbers. This is the bad mamma jamma is what I call him, but he's everywhere. This is an electron microscope image of a periodontal pocket with advanced periodontitis. You can see there's here's the wall pocket. There's white lines, that arrows that show the bacteria that's penetrating in. I have no idea what I'm showing you, but that's what the book says. Okay. Periodontal pocket wall. So as it starts to disintegrate, you start to get your collagen fibers that go away, right? So you have your unattached plaque, you have your attached plaque, and it starts to, you know, disintegrate those collagen fibers. Non-surgical periodontal therapy is scaling and root planing. It is what we do to, we as dental professionals do to eliminate the toxins that are in there, calculus, tartar, or I mean calculus or biofilm. But that is what that is called, is the removal and to try to get them back to a stable, healthy, a stabilized state is non-surgical periodontal therapy. All right, periodontal pocket can become a localized infection. It and affect the fascial spaces, and they may result in an abscess formation with a papule appearing at the gingival surface. Not really going to go into this too much. These are furcations. We'll talk about that in other classes. Tooth mobility, you know, it's very common with periodontitis. These are things that we're going to do in the evaluation process or the assessment process with our patients, is to determine mobility of the teeth. Implant dentinogingival junctional tissues. In regard to newly placed implants, the superior tissue present originates only from the epithelial cells of the oral mucosa, as opposed to junctional epithelium located around the natural teeth, which originate from the reduced enamel epithelium. Structurally, the peri-implant tissue closely resembles a long junctional epithelium, and we don't really get, that's not a really great picture, but perioscopes are pretty cool. They can go into the pocket and help us not see blind, but most of the time we're just blind. But what you can see is everything. I mean, it has a little light on it, it's microfiber, and you're able to get underneath the gum line. Laser therapy is something that we can do here in the state of Maryland. Lasers are currently available for clinical use to remove tissue, soft tissue and hard tissue during surgical periodontal therapy, such as crown lengthening. So you can see that this person went in and had crown lengthening to have that smile design. You can also do laser medicated periodontal therapy, which I think they call LAMAP, which is now being used for non-surgical gingival curettage. So it is to basically clean up the tissue, because think about it, you go in there and, I mean, if you remove all the disease, the tissue still needs to be, and what we're doing when we're hand scaling a lot of the times is our instruments have two cutting edges. One is for actual like removal of deposits, and the other side is for kind of removing that tissue. You do a little bit of that gingival curettage, not taking out the gingiva, just removing that diseased portion of the pocket a little bit. Lasers are currently viewed by some as an adjunct to periodontal therapy for removal of soft tissue within the periodontal pocket. All right, any questions? Okay. All right, let's stop sharing. And then, oops, all right, let me see. Well, take 5, 10, come back at 3:30, because we've been on for another hour. Take 10, and then we'll come back and go through 11 real quick, okay?